The House Health Policy Committee will come to order. Would the clerk please take attendance?
Chair Rogers.
Here.
Representatives Whitsett. Carter.
Here.
Hadsma.
Present.
Neely. Here. Glanville.
Present.
Kafia.
Here.
Conlon.
Here.
Farhat. Fitzgerald.
Here.
Miller.
Here.
Reingans.
Here.
Vanderwall.
Present.
Filler. Mueller.
Here.
Van Workum.
Here.
Roth.
Yes. Yes. I'm here.
Schmaltz.
Here.
Weirdo.
Thompson.
Here.
Madam Chair, you have 16 members present. You do have a quorum.
Thank you. Representative Fitzgerald moves to approve the minutes from our meeting on May 22nd, 2024. Seeing no objection, minutes are approved. Prior to testimony and votes, if you wish to speak and express your opinion on legislation before us today, please submit a card to the clerk. Sergeants in the room will be happy to collect the cards and get them to the committee clerk on your behalf. In the interest of time, you are also welcome to submit written comments to be submitted to the bill record. First, we will refer House Bill 5785 to the Behavioral Health Subcommittee. Clerk Sweet, please read in the letter. Go ahead, use call of the chair. Committee will come back to order.
A letter dated June 13th, 2024. Dear Madam Clerk, on June 5th, 2024, House Bill 5785 was referred to the House Committee on Health Policy. House Bill 5785 addresses the requirements for master's level psychologists. The bill modifies some licensing requirements for limited lifetime psychologists, LLPs. I am asking the Subcommittee on Behavioral Health to review and make recommendations to this bill. With ongoing workforce issues in our state and a lack of behavioral health providers, creating innovative solutions to address the behavioral health needs in our state is vital. I am confident that the subcommittee will be successful and productive. Sincerely, Julie M. Rogers, Chair, House Committee on Health Policy.
Thank you. Today we will hear first testimony on House Bills 5283 and 5284, which facilitate the creation of health data utility. We heard testimony on these bills at our last committee meeting on May 22nd, and will continue with additional testimony as well as have plenty of time for member questions. We will hear testimony on House Bill 5616, sponsored by Representative Steckloff, which would allow medical providers to send eye medications home with patients following use in their office instead of wasting it. And then last up on the agenda for today, we will begin taking testimony on House Bill 4833, Representative Perry's bill, which clarifies licensure for substance use disorder prevention services. We will first have continued testimony on the health data utility bills. As I referenced earlier, House Bills 5283 through 4. Starting us off will be Kim Batchelder, Director of Government Affairs of MyHIN, Eric Roth, Director of Government Affairs at the Michigan Pharmacists Association, and Janine Tyus, the Senior Program Director of the Mid-Michigan Community Health Access Program at the Greater Flint Health Coalition. Also joining us on Zoom will be Isabel Pacheco, Chief Administrative Officer for MyHIN. If you'd all like to come up to the table. After they present, we will have ample time for questions, and I will start off with Representative Van Workum because we did not get to his question last time. Welcome to Health Policy, and begin when you are ready. And Representative Van Workum, you have 10 minutes to figure out what your question was. Begin. Thank you.
Thank you, everyone. Isabel, are you on Zoom? I think you were going to start us off.
I am on. Can you hear me?
Yes, we can. Thank you.
Thank you. Good morning. My name is Dr. Isabel Pacheco, and I'm the Chief Administrative Officer at MyHIN, charged with overseeing operations. Since our inception in 2010, MyHIN has been a leading force in efforts to advance healthcare technology. Created by Michigan's Health Information Technology Commission, which is situated within the Michigan Department of Health and Human Services, our mission is focused on augmenting the healthcare experience elevating quality, and reducing costs for the Michigan population by enabling statewide exchange of health information and furnishing valuable data at the point of care. One of our initiatives to advance this vision involves supporting the establishment of a health data utility. As the largest health information exchange in the state, MyHIN is advocating for health data utility, aiming to improve health data sharing efficiency, accuracy, and security. Establishing a statewide health data utility would ensure standardized data formats, enhance interconnectivity across various provider settings, and provide a centralized, reliable source of patient information. MyHIN is an Amazon Web Services partner. We only use data stores that are included in the high trust scope. All stores are configured to encrypt data at rest and in transit. Only trusted data sharing organizations that have met all legal requirements and agreements can access data, and it is only accessible where an active care relationship exists. The same is true for both adults and minors. There are also opt-out processes in place should a patient wish to opt out of data sharing. This support is pivotal in facilitating improved clinical decision-making, reducing redundancy, and lowering costs by minimizing unnecessary tests and procedures. By delivering the right information for the right patient at the right time, together we can even save lives. I'd like to point your attention to the graphic that was displayed on the screen. Nationally, the
And just
evolution-
one second, I'm just going to point to, we also have a handout at members' desks, so you can look at the handout at your desk if you would like. Continue. Thank you.
Okay. Nationally, the evolution of health information exchanges aligns with the health data utility concept. This documented evolution of health information exchanges you see here reflects a transition from a traditional data exchange model with limited touch points to the current state. Despite this progression, health information exchanges remain restricted to sharing data through traditional healthcare provider settings. Consequently, many providers capable of sharing valuable data to promote comprehensive care presently lack a network connection mechanism. The establishment of a health data utility is poised to dismantle these barriers and data silos, championing the health of all Michigan residents. Thank you. I'll hand it over to Kim.
Thank you, Isabel. And thank you, Chair, members of the committee, for your invitation to speak to you again about House Bill 5283 and 5284. As Isabel mentioned previously, the current statewide HIE was created in partnership with the Michigan Department of Health and Human Services, the federal government, and the Michigan Health Information Technology Commission. The Health Information Technology Commission was created by Public Act 137 of 2006, and according to their website, the commission is housed within MDHHS with the mission to facilitate and promote the design, implementation, operation, and maintenance of an interoperable healthcare information infrastructure in Michigan. Per that Public Act, the commission includes 13 members with representation including MDHHS, DTMB, nonprofit healthcare, hospitals, doctors of medicine, purchasers or employers, consumers, schools of medicine, pharmacies, and third-party payers. In June 2022, the HIT Commission, or the Health Information Technology Commission, released their Michigan Health IT Roadmap, Bridge to Better Health Report, which is on their website, containing 6 priority initiatives. Initiative number 2 is named Enhanced Health Data Utility. The purpose of this initiative is to ensure that core shared services, such as providing attribution, identity management, web services, and data interoperability, continue to be supported and enhanced. House Bill 5283 and House Bill 5284 support building on the success of the Health Information Exchange in Michigan to further the shared data services through creating a health data utility that will support the vision and initiatives set forth for the Health Information Technology Commission roadmap. Thank you.
Thank you. We're going to pause just a second because we have IT things that can go only one at a time. So we're going to come back up a second and get the PowerPoint back up. So
Okay.
one moment and then you all can continue. Thank you for your patience. I'm not sure that we can see all of the screen. Can you come back up? I'm sorry. Thank you. Continue.
Thank you. I will pass to Janae Tice.
Good morning, everyone, and thank you for the opportunity to speak today. I am Janae Tyus. I am the Senior Program Director of the Greater Flint Health Coalition's Mid-Michigan Community Health Access Program. I am also a Commissioner of the State Health Information Technology Commission. In addition to that, I serve as the leader, the chair of the Community Information Exchange, or CIE Advisory Council. So all of this is up in my wheelhouse, but today I bring you kind of perspective from committee about these couple of bills. I am a public health professional, a leader, and just primarily a community servant. I find it a privilege to serve in my seat, and I think I'm here speaking on behalf of the community that I serve, primarily Flint and Genesee County, with reach across Janae's version of Mid-Michigan, which includes 17 additional counties. So, like I said, I'm a servant and invested in the community, and one of the things that I think is a main benefit of these couple of bills to communities is that our communities are a bit disjointed. They are disconnected. Not everyone talks to each other, and individuals who seek care in settings such as ours often seek care in a variety of different settings and systems. And so that means they often have to repeat and reshare things over and over again that might be in one other organizational silo. And what that means is they typically experience adverse health outcomes because they're taking time to remember and recall, and often very limited settings, lots of information pertinent to them and who they are. And we know that truly 80% of what makes an individual healthy occurs outside of a clinical setting. So we need to get these social drivers, these community-based agencies, the dentists and the educational systems really connected and able to share critical information to better serve our communities. So I think this would mitigate some of the barriers associated with lack of awareness across sectors of critical parts of information that are pertinent to the health outcomes of our community. Currently, the distribution of resources in our community-based settings is also a bit inequitable. You've got resources in some domains more than you need, and then you've got a lack of resources than we really do need. So I think that sort of a bill like this, of this nature, would offer us a data-driven approach to equitable standards and equitable access to resources, and communities really do need that. Health-related social needs, as we know, are seen everywhere, but they happen in silos. They're seen everywhere and shared nowhere. So I think this legislation will give us an opportunity to have more visibility of the social needs across the sector and be able to share them. Communities like the ones that I serve tend to operate in a collective impact approach. We all really do work together for the good of the individual, but we can't all see what each other is doing in order to work together and make that individual's care better off. So I think this would allow us, those of us who are invested in our own health and our own communities, to have a comprehensive and more collective view of what's happening from the individual level to the community level and then to the statewide level. Thank you.
All right. Thank you, members of the committee, for the opportunity to testify on these very important pieces of legislation. I'm Dr. Eric Roth. I'm a pharmacist by training, and I am currently the Director of Government Affairs for the Michigan Pharmacists Association. I often note that pharmacists are the most accessible healthcare provider. Roughly 90% of the U.S. population lives within 5 miles of a community pharmacy, and there's no copay required to have a consultation with a pharmacist. However, pharmacies, ironically, have some of the lowest levels of information access to guide them in healthcare decisions with their patients. A health data utility could change that. A health data utility can significantly benefit pharmacy practice by providing a centralized, accessible repository of patient health information. Here are a few of the use cases that show how this would be a key advantage to changing practice. It would improve medication management. Pharmacists can access comprehensive medication histories that would would reduce the risk of adverse drug interactions and ensure appropriate medication use. This is specifically useful for patients utilizing multiple pharmacies and for those with complex, frequently changing medication regimens. It would also enhance patient safety. Access to up-to-date health records help pharmacists identify potential allergies and contraindications, thereby improving patient safety. In the current state, these allergies and reactions are frequently patient self-reported. The picture grows increasingly challenging when patients rely on another individual or even group of individuals to act as their caregivers. Having a unified health record removes the ambiguity that exists in the current system. It would also allow for better care coordination. A health data utility would facilitate seamless information sharing among healthcare providers, enabling pharmacists to collaborate more efficiently with physicians, nurses, and other healthcare professionals. This is especially important as pharmacies are increasingly recognized for the ability to provide convenient accessibility to immunizations and disease state testing. It would help inform clinical decisions. Pharmacists can make more informed clinical decisions with a complete view of the patient's health status, lab results, and treatment plans. It could also allow for pharmacists' clinical recommendations to be easily routed to the rest of the patient's care team after they receive medication therapy management or similar services. And lastly, it would enhance public health monitoring. Aggregated health data can help identify trends and support public health initiatives, such as tracking outbreaks or monitoring medication adherence in the community. By integrating health data utilities into pharmacy practice, pharmacists can improve the quality of care they provide, enhance patient outcomes, and contribute to a more efficient healthcare system. Thank you again for the opportunity to testify in support for this initiative, and I look forward to taking any questions you may have.
Thank you very much. Representative Van Werkum.
Thank you, Madam Chair. I appreciate the time for me to recall what my question was going to be. Mine is more just kind of a pragmatic cost question. I know over time, health systems have spent a lot of money trying to integrate themselves of electronic records and things like that. I guess one is the cost for setting this up and how that's going to be paid. And I know it deals with the insurance pool, but also the cost of the providers, how much it's going to do that, and whether we have an actual system that is going to be capable of doing this. I have spent a lot of time working with DTMB about many different types of software upgrades and programs like that. Are we going to be capable of integrating all of this data and all these systems together, and what is that going to cost for those that are providing the service as well as on the government side?
Great question. Isabel, did you want to take this one? If you're still on Zoom.
Right. So I'll start off by saying that I'm speaking from the lens of MyHIN. Currently, we have the technical infrastructure that acts as the base for this kind of growth. We currently are in partnership with MDHHS, where we do receive funding from the state to help support our operations. This will take our current HIE operations and evolve it into an HDU, which is the second part of this legislation, the funding bill, where we have it set to provide funding to further enhance our technical infrastructure. And Kim, I'll let you speak to the specifics to the funding dollar amounts that are in the second bill, 5284. But to answer your question, because we are already set up with the technical infrastructure to exchange data, this would just enhance that data exchange to include those non-traditional provider settings.
And to reference the House Bill 5284, the first year is at $6 million, and then it increases over the years to $8 million with a CPI, so it caps out at $8 million. The reason why we base the price off the existing infrastructure. Currently, all of the hospitals, payers, the majority of the payers are connected. So utilizing and leveraging an existing health information exchange for the designation of a health data utility, we can leverage the existing technology in place that has already been invested in over the past 14 years, as well as those connections. And that's one of the reasons why we are supporting this legislation as the current statewide HIE, because we believe all of those connections and the investments our stakeholders and our state have made can be the baseline for the health data utility to help bring down those costs.
Thank you, Kim. Minority Vice Chair Vanderwall, did you want to follow up?
Yes, thank you, Madam Chair, and again, thank all of you for being here, and Greg, great representative and working, I'm sorry. Great question. Just a little bit of clarification. Year one is 4 million, year two would go to 6, and then the third year is 8. So it does bump up, and that would be fully implementing the program. Also understand that this money has already been allocated into the system, and this is not new money. This is just shifting some money from what we're currently using and moving it into a new process. So we're not adding to the budget here. I think that's very important for us to understand, and also understand that what this is going to produce better outcomes that actually save the individual money and translates into overall better health outcomes for the entire state of Michigan. Thank you, Madam Chair.
Thank you. Just one point of clarification so we're not confused. 6, 7, 8, I think is what you meant, right? Yeah, 6, 7, 8. Any other questions? So I see Representative Carter and then Representative Thompson.
Yes, thank you, Madam Chair, and thank you all for your testimony. I am a little concerned about privacy, and first of all, I'd like to know whether or not utilizing this database, will that be done without patients knowing about it? And if so, what kind of safeguards do you have in place to protect patient privacy? Thank you.
Yeah, I can start by answering that question. So MyHIN, again, speaking from this lens as the current HIE, we are governed by HIPAA, so we have to follow all of the rules of the HIPAA laws. In addition to that, we go through rigorous certifications, security certifications through High Trust and Direct Trust, and we only partner with security and data stores who are also operating within those frameworks. We also ensure that we do regular stress tests of our system to make sure that we're prepared for any cybersecurity breaches. We put all of our staff through rigorous training, HIPAA and security training annually. And so we are ensuring that we're doing all that we can to protect privacy and security of all the data that's entrusted to us. I'll let Kim add any comments if she has any there.
Yes, and as Isabel mentioned, we are governed by HIPAA. That's what we see the health data utility as well is governed in similar ways. So that would not change the access or the rules and regulations or the level of privacy and security that we currently have right now. We also do have an opt-out process as the current health information exchange that any patient can go to be able to learn more information and then choose to opt out of their data sharing if they wish.
Okay, Madam Chair, thank you. Specifically, when utilizing this program, are you able to access the data of the patient without the patient's consent?
Representative, I'll just speak from the pharmacy ground level because we do interact with the system occasionally. All pharmacies and all healthcare providers are required to provide a notice of informed consent prior to initiating treatment, and that must be done annually. So it cannot be done without the patient's permission. It also still applies, again, under HIPAA to the minimum necessary rule, where any healthcare provider accessing the system cannot access anything that would not be within the scope of care for that patient. So a patient's consent is required, and the data is still protected to the extent that it needs to be used for therapy.
Thank you. Representative Thompson.
Thank you, Madam Chair. My question is, if this legislation, or how would this legislation affect access to vaccine and immunization data?
Certainly, and I can take that one as well. And I'll speak to some of my personal experience running an immunization program during the height of the pandemic. We relied heavily to make sure that patients were receiving appropriate vaccines during these large-scale vaccination clinics on the Michigan Care Improvement Registry, or MICR. That's the current immunization database that is available to healthcare providers throughout the state. I cannot tell you or emphasize enough how many times we found errors or omissions in the data under the current system. So what we really foresee this looking like is a implementation of a better version of the existing system, one that is reflected across providers' offices, would be theoretically supplemented by health records rather than just data that was put into a separate standalone registry, and ultimately eliminating misadventures by over-vaccinating a patient or catching a disqualifying condition that may make them ineligible to the vaccine. So in short, to answer your question, we would be utilizing a better version of existing tools to greater efficacy.
And who else other than healthcare providers would have access to that data?
My understanding is it would only be healthcare providers because, again, this is all governed under HIPAA. Anything that would be used for a public health type of utility would have to be de-identified and not be directly tied to any patient under existing HIPAA regulations.
I think I got a little confused when we saw the big wheel of all the entities that would get this information and have access to it. Some of them were food banks, community information exchange, schools. That tells me that my health record is going to be going to these entities, or they're going to be able to access it. And you're telling me that that's not the case.
I'll let my colleagues over here at MyHen, but again, it's all of the existing privacy regulations would apply, at least at the provider level.
Yep. So under the provider level, for example, the current statewide health information exchange is working with some schools or in some school districts currently right now. They have behavioral health licensed providers at that school. They are the ones that are able to access the information because they are governed by HIPAA. The school officials, school counselors, et cetera, do not have access to that information. When it comes to community, I'll let Janae speak on that. But however, the information, the whole medical record is not shared. Underneath HIPAA, there is a minimum necessary. So if there is a community organization, only the minimum necessary, and I think that's part of the health data utility, is understanding consent to some of that information that will be shared between the community and the health information exchange, and the consent process for that. However, again, those folks on that diagram, those different organizations, will only receive the information if the proper laws, the proper legal agreements, and the proper acres or active care relationship is in place, and they will only receive the minimum necessary in order to perform their duties. I don't know, Janae, if you want to add to that.
I think you actually covered it really well. I think what the diagram is showing is the potential future. I think very rarely do people realize that healthcare does occur in, community-based settings. So there are schools with regional alliances for healthy schools where they're getting immunized, or there are communities that operate like mine where we do have a community information exchange where we have clinical providers, hospital systems, specialty providers, and primary care providers all working together, and payers, to facilitate better health for individuals. But that doesn't occur without the necessary legal guardrails in order for us to share information and see information about individuals. And rarely ever is it on an individual level that we need it in that way. We need it on an aggregate basis. And we've established with MyHen the legal guardrails and the individual informed consent practices to make sure folks know where their information is going, how they can augment, edit, or use it if they want to in the future. And then communities are responsible for sort of adhering to the practices that we've agreed to legally. Hope that helps.
Thank you. And then I think Minority Vice Chair Vanderwall had a follow-up.
Thank you, Madam Chair. And again, thanks. This kind of goes back to the pharmaceutical side of things. We currently have a system called MAPS that you guys, which is wide open, from what I understand. How do you believe that this system would help better control some of our opioid crisis that potentially, we know is out and rampant right now versus what we currently have?
I may rely on some of my colleagues at my end to talk about the current integration of MAPS into the Health Information Exchange, but I can speak broadly about what programs like MAPS or prescription drug monitoring programs that are similar are utilized to do. A pharmacy is required to document every dispensing of a controlled substance, including opiates, and physicians and prescribers are required to check the Controlled Substance Registry prior to issuing a new prescription. Whenever we can centralize this data and integrate seamlessly across platforms, it is reducing the likelihood that something is going to slip through the cracks, that there is going to be an incident that was overlooked during care delivery. So again, wherever we can tighten this and move these types of systems into a centralized repository, it increases our ability to utilize the tools that are already being effectively utilized and makes it more seamless for the actual delivery of care at the point of care. I hope that answers your question.
Thank you.
Thank you, Representative.
And if I could add to that, please, MyHIN is currently undergoing an initiative to bring together the data for patients, the medication and prescription data. Today, the MAPS program is only monitoring controlled substance prescribing or dispensations. What we are aiming to do through this is to get information on both what was prescribed and what was dispensed. This helps prevent medication errors, duplication of therapy, drug interactions, etc. And so bringing together the whole picture of what the prescriber prescribed versus what the pharmacy dispensed is also something that we hope that we will be able to push forward as well.
Thank you. Representative Reinkens and then Mueller.
Thank you, Madam Chair. So I, in some of my past work, worked a little bit with MyHIN on data exchange at the community level. And one thing that was really helpful to me, and my question is to please correct this, is that MyHIN as a health information exchange is pipes through which entities can send information, but only if you can unlock the door for that information to go to the other organization. So your health record may live in a hospital or your primary care office, and if you go to another hospital emergency room, they need to know if you're allergic to stuff. So they send a little note through the pipe, and it goes through the direction to ask, can we have this information? If the patient has agreed with that other hospital that it is okay to share that information, then that hospital will say, is this the same patient? They'll do a check to make sure it is actually the same human for whom you're asking the information, and then they will send only that information that was requested. They're not going to share your whole entire life health record. They'll only share the information that was requested to that emergency room who needs to know if they're going to kill you with the drug they're going to give you to save you. So that is the way I understood it. And only once other entities sign on with data agreements and data protection agreements under penalty of law and prosecution for sharing unnecessary data can they join their pipe to the pipeline, is how I understood it. I'm seeing people nodding. Am I simplifying it too much?
No, that was a
is
great
correct.
explanation. Thank you.
Thank you. We're going to move along to Representative Mueller.
Thank you, Madam Chair. Really quick, with a consent, do the people have to consent to do it, or is it automatically done and they have to opt out? And the second question is, I know there's a form on the page to opt out. Is that form provided to the patients when they go in to see their caregivers, or is that something, because these bureaucratic bait and switch forms are terrible for our constituents to figure out. They might sign one thing, but they're getting another because of the way it's written. It's written by policy people, not people that just want to go in and say, I don't want my record shared. So we want to make sure that it's easy for them to know that I'm not going to share my information, that's my choice, or if I want to share that information, make it easy for the people to opt out or opt in. I know there's some federal laws or something like that that doesn't allow for opting out possibly, but you need to make it easier for the consumer to understand their privacy before they just go in. Because a lot of times when people go to the doctor, one, they're not in the right state of mind, they're rushed, there's a bunch of forms, they don't understand them. It needs to be really simplified before, a lot of people get on board on that.
I can take the first part of that. So underneath HIPAA, I believe, Eric, you had mentioned within the patient's visit yearly, they sign the HIPAA authorization form. According to HIPAA, that information can be shared for payment, treatment, and operations purposes. According to Representative Reagan's example, that's where that current health information exchange can assist with that data sharing. Again, as I mentioned before, we do have an opt-out process on the MyHIN's website, just for the extra layer of protection if a patient would like to opt out of the process. But currently, the health information exchange is an opt-in through that HIPAA consent form process. It's at the provider's office. When it relates to more specially protected information, currently the health information exchange does not have opioid, specially protected information. We're currently building a consent infrastructure that will support patient consent to share that, because there's the federal rules of 42 CFR Part 2, where there is specific consent for substance abuse and opioid use disorder information to flow, and that's where we see this infrastructure leading to through the health data utility as well. I don't know, Isabella, if you want to add any of that, or
I think we're for time, so I really appreciate everyone's testimony and questions. I want to reference the cards a minute. So Vital Data Technology has put in a card of support on both 5283 and 5284. Department of Health and Human Services opposes both bills, 5283 and 5284. Scott Monteith supports the bills. Greg Forsley also supports both bills. Tom Simmer supports both bills. Kevin Bonsack supports both bills. Dennis Smith supports both bills. Larry Wagenite, RPH, supports both bills. We also received a number of emails opposing 5283, which will be uploaded by the clerk onto the website. Again, I really appreciate everyone's input. If you have additional suggestions for the bills, please reach out to my office, and we look forward to moving this legislation in the coming weeks. Next up on the agenda, thank you so much for waiting patiently. We have 5616, sponsored by Representative Steckloff. We will first have her testify, followed by Maura Campbell, Executive Director of MySIPS, which is Michigan Society of Eye Physicians and Surgeons, and Dr. Deanna Ingracia Miano, ophthalmology resident of Ascension Eye Institute, and you can all come up together if that is okay. Welcome to Health Policy. Begin whenever you're ready.
Thank you, Chair Rogers, Vice Chair Whitsett, Minority Vice Chair Vanderwall. Thank you for allowing us to testify today on an issue that impacts both the financial burden on patients and the efficiency in our healthcare system. Namely, I want to address a very specific inefficiency within our healthcare system regarding the handling of eye drops and ointments provided to patients in clinics and hospitals. This bill was brought to me by a dedicated constituent who is an ophthalmologist. During his residency in Illinois, where the practice is already law, he witnessed firsthand the benefits of allowing patients to take home their prescribed medications. Then upon moving to Michigan, he was stunned and perturbed to find that such a sensible practice was not in place here in the state of Michigan. You see, currently, when a patient requires treatment with these medications during their stay, any unused portions or must be discarded when they leave the facility. Consequently, patients must obtain new prescriptions, go to a pharmacy, and get the exact same thing they were already taking just to continue their treatment at home. It often incurs additional costs and faces potential delays in receiving their medication. By allowing patients to take their prescribed eye drops and ointments home, we inadvertently increase the financial burden on our healthcare system and our constituents. What's more, with all the duplicative waste, this practice is not only economically insufficient, but also environmentally inconsistent. It is time for Michigan law to evolve to meet the practical needs of our residents. So let's employ some common sense here and modify our regulations to permit patients to take home eye drops and ointments they have already been prescribed and start using during their medical care. This change will streamline treatment, reduce costs for both patients and the healthcare industry, and minimize medical waste. Following my testimony, you will hear from two esteemed ophthalmologists who can provide detailed technical insights and further elaborate on the benefits of this proposed change. Thank you for your consideration and commitment in improving the healthcare and well-being for the people of Michigan.
Thank you, Representative Steckloff. We're going to hold questions until all three of you have testified. Welcome.
Thank you so much for this opportunity. I am not an ophthalmologist. I am standing in for Dr. Westhouse, who had 90 patients to see. And it was going to be a very long day. He's an excellent retina specialist on the West Side and also a fabulous legislative chair. I represent the eye doctors that went to medical school, so the Michigan Society of Eye Physicians and Surgeons. And our members are extremely excited and very much in favor of this proposed legislation, especially our young physicians like Dr. Miano. They don't get why we waste so much in the medical field, why so much is dumped and ends up in the landfill. And they certainly don't understand when they're trying to care for a patient who might have a real difficulty with access to care and needs to immediately be using the drops that they are or ointments that they have been prescribed when they leave wherever they had their care, whether that's an ambulatory surgical facility or a hospital, that there's no delay in care. And yet they have to throw out almost full bottles of sometimes very expensive medication, and then that patient has to go and get the exact same thing. But sometimes there's a delay if they don't have transportation, if it's later in the day and they can't get to their pharmacy. So I just want to say that this is one of the changes that our members have been the most excited about, and I now would like Dr. Miano to speak from her perspective.
Thank you, Maura. And thank you guys for the opportunity to speak with you today. My name is Deanna Ingrassi-Miano, and I'm a physician representing the Michigan Society of Eye Physicians and Surgeons. I'm here to advocate for legislation that permits hospitals, emergency rooms, and outpatient surgery centers to send home eye drop medications with patients. As a society, we feel as though this initiative is critical for reducing medical waste, optimizing healthcare resources, and more effectively caring for our patients. As a resident physician in the Metro Detroit area, I, along with countless colleagues within the state of Michigan as well as the country, care for many underserved patient populations and therefore see firsthand how such hurdles for our patients can be alleviated. Our goal is to ensure prescribed topical eye medications or drops that are partially used for the patient within our facilities can be taken home with them should they need it for continuing care. Today, the patient is not provided with that medication despite a majority of the medicine still remaining in the bottle. The remainder is discarded, and then the patient must pick up a new bottle of the same medication from their personal pharmacy. Extra medication, extra cost, unnecessary waste, and most of all, patient burden. This disposal of partially used eye drops bottles contributes significantly to medical waste. This is a problem across the map, locally and nationally. At a time where we know prescription costs are a worry to our patients, it doesn't really make sense for them to pay for medications once within the healthcare facility and then a second time in their personal pharmacies. The point becomes even more magnified when the medication that is thrown out is even more difficult for them to obtain in the outpatient setting because of medication shortages. I have some numbers for you, so bear with me here. The United States healthcare system generates millions of tons of waste each year, with a considerable portion coming from unused medications. A 2019 report evaluating waste in surgery centers found an average of $148 of unused or partially used medications were discarded after a single cataract surgery. With 3.8 million cataract surgeries performed in the United States each year, this would amount to $560 million of medication discarded, medication that our patients have already paid for. I'd like to highlight 3 scenarios for you that us as ophthalmologists in the communities of Michigan encounter regularly. The first I already somewhat alluded to, which is cataract surgery. In the outpatient setting, our patients pay for perioperative drops. This includes dilation drops, which are these 2 red drops. We have an anti-inflammatory drop, a steroid drop, and an antibiotic drop. We use 1 to maybe 3 drops, not a bottle. We use 1 to maybe 3 of these drops per patient, per eye, during the perioperative period. As soon as we close up for surgery and they're done, we toss this away. This is completely gone. But then we see our patient on the post-op day 1, and we expect them to have this very packet, a duplicate, with them to start on day 1. This is completely redundant. This is just additional cost to our patients, and again, because of the social barriers that they may encounter, it's difficult for them to sometimes obtain these, and then that's a compromise of care. The second scenario occurs when the patient is seen at the emergency room. For instance, let's say they have acute angle closure glaucoma. That's when we use a cocktail of these drops here, and we titrate them down, or we titrate their pressure down so that they're more controlled. And again, this is visually significant, meaning if this is untreated, they can have permanent vision loss. We wait, we get their pressure under control. When they leave that facility, I toss this. But I have to tell the patient that you're at high risk of recurrence, and you need to pick these drops up immediately. And this can be a burden, especially when our patients maybe don't have rides. Perhaps their mail order pharmacies can't get their medications in on time. So again, a risk to patient care, and this can absolutely be avoided if I could just hand this packet right over to them. My last example is regarding patients who are admitted to the hospital for non-ocular disease. Perhaps you have a family member who's admitted for uncontrolled hypertension. All their medications that are started outside of the, or that they're taking outside the hospital, such as diabetic medication, high cholesterol medication, or their glaucoma drops, are started when they're inpatient. So let's say we give them 1 of these bottles to start while inpatient. After 3 days or so, when they're finally discharged, this bottle cannot go with them. And despite having a 30-day supply here and only 3 days worth being used, this is tossed. This is roughly anywhere between $30 to $40. And so this is, again, extremely redundant and extremely wasteful to not just the economy, but also medication and plastic waste. So while the aforementioned examples only breach the surface, I could tell you so many more, but I ran out of pockets and I don't have enough drops. This, I hope, gives you a glimpse into what we're seeing with our patients and the hurdles that they have to face. Aside from a medical waste aspect, though, I did want to expand upon the latter point of patient compliance. So when patients are intended to take drops frequently, sometimes every 2 hours, so it's a lot, time is of the essence. So when they're intended to take the drops this frequently, this regimen is super important because of the fragility of their ocular condition. When patients can't obtain their rides to the pharmacies, or their mail order pharmacies can't get their urgent prescriptions in, or preferred pharmacies are out of stock in their intended medication, we feel as though this is a compromised care in an absolutely avoidable way. This bill will ensure immediate medical access, thereby improving adherence and prescribing treatment regimens and ultimately reducing the risk of complication. We feel as though this is a standard of care, and we owe it to our patients to advocate for their vision and overall quality of life. Lastly, along with the reduction of financial waste and improved patient compliance, this bill offers environmental benefits. In a society that calls for reduce, reuse, recycle, the environmental impact of medical waste cannot be overlooked. By reducing the volume of eye drops that are discarded, we contribute to a more sustainable healthcare system and promote environmental stewardship. So, in closing, I understand there may be some concerns regarding the logistics and safety of this proposal, and it's important to note that 1, proper guidelines and protocols can be established to ensure that only safe and appropriate ocular medications are sent home. 2, clear instructions and education can be provided to patients to ensure they understand how to use and store their drops, which, to be honest with you, is already done by a majority of our healthcare professionals in the state. And 3, similar practices have been successfully implemented in states, which provided us with a model for how to achieve this safely and effectively. We've worked closely with the State Ophthalmology Society in Illinois, and our bill emulates that of their own, which was passed in 2021. So in closing, allowing eye drops to be sent home with patients is a practical and beneficial policy change. It aligns with our goals of reducing medical waste, enhancing patient care, improving healthcare efficiency, and promoting environmental responsibility. We, as a society, urge the committee to support this legislation and take steps towards a more sustainable and patient-centered healthcare system. I can leave you with additional materials if you're interested, but I really appreciate your time and your consideration today, and I'm happy to answer any questions you may have.
Thank you so much. Do we have any questions from members? I will ask a question as people are thinking about it. You referenced the Illinois legislation in 2021, so that's been stood up for a number of years. Have there been any adverse effects from that legislation that you're aware of?
I talked to Dr. Palmer at length, and he was one of the people behind that legislation. I think I spent an hour on the phone with him, and he sent additional information. And he said, no, they really haven't. It's been a really big success in Illinois, and he was really excited and has continued to offer any support he could because he wanted Michigan to pass it as well. Delaware and Tennessee have also passed similar legislation.
Thank you so much. Representative Carter.
Thank you, Madam Chair, and thank you all for your testimony. This bill just makes good sense, period. Now, you think about our senior population and people who live in rural areas that you can't get back and forth to the doctor, or you don't have transportation, you have transportation insecurities. Why would you throw the medicine away? It just makes good sense. That's a statement, not a question. Thank you, Madam Chair.
All right. Any other questions or Representative Conlon?
I will just add my thank you, Madam Chair. Thank you for your testimony. My daughter, who's currently at school in LA, got a horrible eye infection from her contacts, and and was getting on a flight to come back to Michigan, and she couldn't fill this prescription. They gave her some in there because she didn't have time. Had to fly back with this horrible, and we had to go to Kellogg Eye Center, and it was a very dangerous situation she was in, and she had to wait, 24 hours till we could get her in Michigan in the eye clinic to get those drops.
Thank you. All right, seeing no other questions, I will read in the cards supporting HB 5616 MSMS and supporting the bill, Eye Care Partners. Thank you to everyone who testified today. If you do have questions regarding HB 5616, please let either my office or Representative Steckloffs know. My intention is to take this up for a vote very soon. And we have one more bill on the agenda, House Bill 4833, which would make clarifications to Michigan's substance use disorder licensure statute to eliminate a duplicative licensure requirement. Representative Peary, the bill sponsor, is unavailable today due to a prior engagement, but to speak to the bill, we have Chair Felicia Braybeck, the Behavioral Health Subcommittee Chair, as well as Mac Jones from Lara's Office of Policy and Legislative Affairs. And do we also have Heather Hosey? Yes. So all three, if you would like to come up at the same time, we would appreciate that. And thank you for your patience, Chair Braybeck. Welcome to Health Policy, and begin when you're ready.
Good morning, Chair Rogers, members of the committee. Thanks so much for having us here today. Again, as the chair said, I'm here in my capacity as a chair of behavioral health in support of House Bill 4833, which is sponsored by Representative Puri. I've had the opportunity to review the legislation. I've had conversations not only with Rep. Puri, but with his staff and stakeholders to ensure that we both maintain important protections for patients receiving services while also reducing duplicative licensure and administrative burdens. In May of 2020, the department, Lara, convened a substance use disorder rules work group, which identified several items that required alteration in state law, but could not be addressed through the rulemaking process. So stakeholders in that work group identified prevention services, namely substance use disorder educational programming and duplication of licensure as items needing legislative action. What House Bill 4833 clarifies is that entities are required to maintain a license for substance use disorder treatment or rehabilitative services. The practical result of the current law is that some providers are required to maintain duplicate license, and the department is obligated then to perform licensure functions on the same entities for overlapping licensure requirements. So 4833 allows a licensed psychological, medical, or social service provider, a substance use disorder educator, not providing treatment, or a hospital or psychiatric hospital that is already licensed in the state to be exempt from additional licensure for substance use disorder treatment. So we're streamlining and clarifying the licensure requirements, and this allows the state to be more efficient, particularly in allocation of its resources, but it also reduces the administrative burden for educational and otherwise licensed providers. This is something that we've talked about many times in behavioral health, is that administrative burden. So this is one of the things that we can do to really address that. So I'd like to thank you for your consideration of this legislation, truly in how to streamline how Michigan addresses substance use disorder licensure. And I look forward to answering any questions and for your support in this.
Thank you so much. I think we're going to hold questions till all three, so continue. Welcome.
Good morning, representatives, and good morning, and thank you, Chair, for taking this up. I just quickly wanted to just sort of reemphasize with the department. Representative Braybeck did a good job of giving an overview as to where this started. So I wanted to emphasize that the department still is going to be retaining oversight over these programs under other areas under the Public Health Code through their licensures set up that way. And primarily the department's trying to prioritize the staffing resources that we have on this, on substance use disorders towards treatment services, and as Representative Brayback mentioned, it does relieve some administrative burden from the department's perspective to do our licensing process for 2 licenses as opposed to just 1. So happy to answer any questions you may have. And yeah.
Did you have additional or just for questions? Okay.
Yep.
Representative Reingans.
Thank you, Chair. I'm trying to read through this bill. This is only for licensing of facilities, not of health professionals.
That is correct, yes.
So health professionals are already licensed under the Public Health Code, and they could be licensed for any number of services, but this doesn't make it so that somebody could still practice substance use disorder treatment or rehabilitation services if they don't have a health professions license. They must still have that health professions license.
Correct, yes.
That's where the redundancy is. This is only for the facilities.
Correct.
Thank you.
Any other questions? Okay, thank you very much. I appreciate your testimony. We do have Michigan Health and Hospital Association with a card of support on House Bill 4833. Once again, if you have suggestions for the bills that we heard testimony on today, please reach out to the bill sponsors and or my office. Vice Chair Whitsett moves to excuse absent members. There being no objection, the motion prevailed by unanimous consent. There being no further business before the committee will stand adjourned.